All right, are we ready?
Yes.
RCT. So this is the last lecture bit you'll be pleased to know. And then we're going to get on to actually read some RCTs and see what we make of them. So we're just going to go through some of the design aspects of an RCT. We've touched on a fair bit of this already, and we're going into a little bit more detail, and hopefully that will set us up nicely for the workshop task. So, RCTs are often called the gold standard, the big cheese, the daddy of how we test whether an intervention works. I don't think there's ever been a time in the therapies where the primacy of RCTs in terms of determining effectiveness hasn't been questioned at conferences, and how they're not appropriate for physio, you'll hear, and all of these other arguments. But I think when it comes down to it, most of those arguments don't hold. We'll touch on them. There are definite limitations to RCTs. They can tell you very specific things, and there's detail and nuances that we would love to know that we can't get from an RCT. But if we want to know whether delivering a treatment is effective, we need to compare that with something else. And we really need to build randomization in there so that we can be sure at the end that if there is a difference, it was caused by the intervention. So, what's going on?
I'm going to teach you. Ready? You just have to hit it. Try it.
We're in. So we look at a basic observational study for how we might look at whether an intervention is helpful. It looks a bit like this. It's the same thing, really, a formalized version of what you might do in the clinic, which is measure your variable of interest, deliver the intervention, and then measure that variable of interest after to see if it's changed. And you guys now know, or knew before anyway, why that isn't necessarily a great way of determining treatment effectiveness, because there's all sorts of reasons that might have driven the change other than the treatment itself, absolutely. So the solution to that is, of course, to build in a control group and compare it to a control group who essentially go through exactly the same process, except for the fact that they don't have the treatment. They have something else or nothing. So if we do this, then we can compare between the groups afterwards, and that should estimate the effect of the treatment, the difference in the two groups after the treatment. Is everyone happy with that? Is there a problem with this diagram though? Is there a way there could still be another explanation? I recruit a treatment group and I measure them at baseline, give them the intervention and follow them up. I recruit a control group. I don't give them the intervention, I'll give them whatever the control condition is, and I'll follow them up and I compare between the groups afterwards. But is there a potential problem with this? At least in the way that it's depicted. It's not randomized, and these two groups, at least the way that the illustration is drawn, are essentially separate. I've recruited them separately. And so what if these groups are different in some way that actually is the reason that they're different afterwards on the outcome of interest? And the solution to that, as Sandy quite rightly said, is to make sure we recruit our group from the same population, take our baseline measures, and then randomly allocate them to either get the intervention or the control, and then measure them after the intervention. And that comparison there on our outcome gives us the effect size, the effect of the treatment itself. And we can more confidently, if the trial is delivered well, draw a causal inference. We can say that the treatment caused the difference. Make sense? Lots of different types of design of RCTs. I'm just going to go over the four key ones. The classic RCT, the one I've just shown you, is the parallel RCT. You have two groups, you might have three groups. You randomly allocate people to the groups and then you follow them over that time. But people only get randomized to one group in that instance. Yeah? So that's the classic model of the RCT. There are more efficient models for certain types of interventions. People are familiar with crossover designs. So in a crossover design, people essentially act as their own controls. Everyone gets the treatment and the control condition. So we take our population, we sample from it, we then randomly allocate them to get the treatment or the control, measure afterwards, observe a washout period where we hope everything returns to baseline normal, and then swap the groups over. So those who got, for instance, if it was a placebo-controlled trial, those who got the treatment in the first phase get the placebo in the second phase. Those who get the placebo in the first phase get the treatment in the second phase. Make sense? What kind of treatments would this not be appropriate for, do you
to make a long-term effect.
Exactly that. Any treatment that's going to have a lasting effect isn't going to be suitable for a crossover study, because when you have your washout period, you're not expecting people to return back to baseline. And of course, the biggest threat to the validity of a crossover study was there that baseline equivalence after the first period of time?
Why would you choose fluorescence?
Because it's quicker and it's cheaper and you need fewer people, essentially. So it's a more efficient design, but there's only there's a limited number of interventions that you could use them for. And interestingly, actually, when you review in studies, crossover studies are often very difficult to implement because that baseline equivalence issue halfway.
But you might do that on, for example, a drug that's aimed at lowering blood pressure. The idea is that you're going to take that forever.
Yeah.
So you might do it with that sort of where you've got a chronic disease, but treatment has a really short effect.
Or most painkillers. If we want to ask slightly more complicated questions, then we might move up to a factorial design. We might want to know whether more than one intervention might interact. So you might ask a question, does intervention A work? Does intervention B work? Or does intervention A plus B work more? Does that make sense? Yeah. And in that instance, we might use a factorial design. So an example of that might be, does spinal manual therapy work better than CBT, or is giving both together more effective? So this is a sort of terrible diagram of a classic drug factorial design. You take our sample from a population, you randomize them. We've got two drugs, drug A and drug B. So one group get drug A and B, one group get drug A and placebo, one group get placebo and drug B, and one group get both placebos. Yeah, and then we can tell quite a lot. We can infer more things because there's a higher number of comparisons. If we go back to the example of CBT and spinal manual therapy in our trial, we'd randomize one group to get CBT plus manual therapy, one group to get manual therapy, one group to get CBT only. Let me go through this again. I'm coming right back. One group's going to get SMT and CBT. Right? One group will get CBT, but they won't get spinal manual therapy. One group won't get CBT, but will get spinal manual therapy. And one group don't get anything. Okay? So then we've got the comparison of each intervention versus no treatment, and the comparison of both interventions combined. Make sense? Analyzing those studies or interpreting the analysis of those studies can be really challenging. Cluster RCTs are essentially just RCTs, but instead of randomly allocating people to different groups, we randomly allocate at the level of the recruitment site usually. So it might be that I randomly allocate GP practices or physiotherapy clinics or schools. So these are much more commonly used with things like public health interventions, where it's very hard to deliver it to one person in a group without other people hearing about it, getting contaminated. So it's easier to randomize at the level of the practice than the person. Of course, in order for that to work, you need big numbers for a cluster RCT. What was your cluster RCT that you were talking about earlier? What sort of question was that?
Is the kids one?
I don't know. You said you had a grant in for a cluster RCT.
Yeah, so that was. It's it's complicated. So this was so we're working with some people to do interventions in schools. So, and these are they're interventions aimed at essentially aimed at creating an environment to make physical activity easier for schools. So they train PE teachers to deliver this physical education interventions to schools. So schools get randomised to either the intervention or the outcome. Then you go and measure the outcome of kids. So did they do physical activity? But you randomise the school. And so you might have a big study that about 100 schools, like that. So then you've got thousands of kids. So the end is thousands, but actually the number of sites randomised.
Cool. So when you see a cluster RCT, that's the key message there, that they haven't randomized people to groups, they've generally randomized recruitment centers to groups.
So that has implications in for our group study, who you've actually randomized. You don't have the same power that you would have in an RCT where you've randomized all those individuals. You also have more power than you would if you just randomized the number of schools. So it's something to the calculation. Yes, statistician do that.
So we've already touched on this when we did our question, when we were trying to decide what is the question we were asking about dry needling, right, this morning. And there are different types of trial. You can kind of break them down into explanatory or efficacy trials, which is really asking, does this treatment work under ideal conditions, or does it have a specific effect, an active ingredient specific effect? And so explanatory or efficacy trials is telling you something about the mechanism of behind the outcomes that you observe, right? So we were looking at an efficacy or an explanatory trial when we decided in the end we use a placebo control rather than a usual care control. Or we could be more pragmatic and we can say, well, we're not that interested in how it works. We just want to know if you roll this stuff out, pay for it and give it to patients, do they end up better than not doing it? And in that instance, you might compare with no treatment or usual care. So that's more of a pragmatic trial, and that's more about effectiveness. So I think, people often use the words efficacy and effectiveness interchangeably, but that can be quite confusing. When we're talking about efficacy, we really are looking at, how does it work? Does it work for the reasons that we say it works under very controlled conditions? When we're asking about effectiveness, it's more about when we roll this out into the real world, does it deliver better outcomes? Yeah. And then, of course, we can just compare different treatments. We can do comparative efficacy or comparative effectiveness, looking at the comparative effectiveness of two different treatments. The interesting thing about efficacy and effectiveness was, I was saying earlier, I'm much more interested in the placebo-controlled question. And Steve was saying, well, I'm less interested in that. And it's, what do we do in the instance that we cannot demonstrate efficacy for an intervention? It doesn't perform better than sham, pretending to do it. But we've got evidence that better than not doing it, people tend to be better. What do we do under those circumstances? Do we do it anyway, or do we not? This is, a live debate, and I don't know I know what I think the answer is, but that's an aside. But what do we do there? If we know that our treatment doesn't outperform placebo controls, but it does seem to make people feel better, how does that impact how we use that evidence, do you think? Anyone got a view?
I think if the patient has informed consent about the research and they know that it doesn't perform better than placebo,
Yeah.
they still want it. You can give it to them.
So when you say it performs, did they feel better compared to what?
Usual care, no treatment. Let's say no treatment for the sake of simplicity.
What are you asking about?
Well, I'm asking, let's say we have an intervention. For instance, and this isn't based on data, but since we had the example, dry needling, right? And let's say we have a decent body of evidence that with some confidence we can say it doesn't outperform sham. It is not better than placebo control. But compared to not doing it, it returns better outcomes.
It's always like a risk reward analysis too.
So you touched on a really important thing there about informed consent.
Are they gonna have to do this forever? Like, is this something that's like we do it once and they feel better?
Yeah.
Maybe that's less bad than we have to keep doing it forever.
Yeah, I guess the latter situation is the more likely, seeing persistent pain, that this is something that will help short term, but might not. I think the informed consent thing is really interesting there. You see, because there's an argument, of course, that if you tell a patient it doesn't work better than pretending to do it, then you might not get that difference against no treatment. Although there are some studies that suggest that might not be the case. But I think it's a really interesting question.
I wonder if there's a subset of patients where one works better because that data, when you send it, would be some sort of type of response.
So the subgroup question, is there a subgroup of people that this treatment does work for?
Identified based on we identify the traits,
Sure.
And then you could,
Yeah, I mean, and subgroups are kind of the holy grail for almost every intervention ever tested, particularly the ones for which when we roll it out, doesn't really show very much. Then we always end up wanting to know whether there were subgroups of responders, and we'll talk about that a bit in a minute. So we've got specific and non-specific effects that we're estimating in trials. The specific effects, we're really talking about the effect of the proposed active ingredient or mechanism of therapy. And the non-specific effects are pretty much everything else, right, that can explain that change in pain, from placebo effects. Is anyone familiar with frustrebo effects? So let's say I've got a trial of let's have something else, ultrasound for back pain. And ultrasound's been getting loads of good press in the crappy media recently, and lots of patients want to try this new singing, all dancing ultrasound. I know it's kind of unfeasible, but let's just take it as read that that's the case. So then these guys, they've had every other treatment, and they come into the trial, and it's a trial of ultrasound. I think, I'm finally going to get a crack at this. That's why they signed up for the trial. And then they get randomized to usual care, which is go back to your GP. Now that could demoralize people, that could make them feel pretty down about their symptoms, that could put them on hold in terms of sort of allowing improvement to happen. It could affect how they report their outcomes. So we talk about the placebo effect in terms of that non-specific effect of having received the theatre of care and that expectation that the treatment will benefit you. But there might also be nocebo and frustrebo effects that work in the other direction, of being randomized not to get the thing that you wanted as well. The Hawthorne effect really isn't specific to it. It refers to this idea that people who are part of a study and being observed behave differently. So if we look at these basic comparisons we might make in the average trial, we can compare the active intervention to a sham, which is what we ended up doing with dry needling. We can compare it to no treatment or usual care. But usual care is a very variable feast, so for simplicity, let's call it no treatment. And depending on what we're comparing it to, very much changes the question that we're asking, as Steve showed in one of his first slides this morning. If I compare the active intervention and sham, then any difference I'm observing, we can attribute to the active ingredient of the intervention itself, assuming that the sham has credibility, and it might not even be that it has to be completely indistinguishable from the intervention, but it needs to be credible. It needs to be credible to people. If we compare the active intervention to no treatment, then we're still measuring the active ingredient of the intervention, if there is one, but we're also measuring all those non-specific effects of receiving care. And if we compare sham with no treatment, then we're actually quantifying those non-specific effects. Yeah? So, that's our best estimate of placebo effects often. And then there's a Cochrane review of what is the size of placebo effects in clinical trials. And that specifically looks at comparisons of placebo versus no treatment. Make sense? So back to randomization, because actually, RCTs, I think, are the simplest design on paper. Doing them, luckily I don't have to, Steve's done a bit of it, isn't so simple. But, the principles behind them are really easy to wrap your head around. And the basic thing is that the gold thing in an RCT, which makes it special, is randomization. It's vital. And the point of randomization is that we end up with a group of people in each group that are essentially not different on any variable, right? That we balance our groups, and any difference that has occurred between our groups has literally occurred through chance alone. So I had this lovely video of Donald Rumsfeld making a speech after the Iraq war, and it's not working. But you might remember the speech. It was about after the invasion of Iraq, they ended up looking for the weapons of mass destruction, which was the justification for going in the first place. And someone was asking Donald about how the search for WMDs was going, and he said, look, there are known knowns. There are things we know that we know. There are known unknowns. That is, there's things that we know we don't know. And then there are unknown unknowns. These are the things that we don't know we don't know. Then the journalist said, and which is this? And he said, I'm not going to answer that question. But actually, while he was obviously obfuscating, there's a real truth in there that gets to the point of why we randomize in the first place. I could easily select groups and balance them on variables I know that are important, like the duration of how long they've had their symptoms, gender balance, age, weight, any of those things, you could do it. I can't balance them on things that I think are important, but I can't measure, like the known unknowns. But importantly, I can't balance them on things I don't even know might be important, mediators of effect size. But if I randomly allocate them, and it's a truly random process, then I can be confident at the end that those groups will be balanced on the known knowns, the known unknowns, and the unknown unknowns. And it's on that basis that we use RCTs to draw causal inference about why that treatments actually caused the effects, and why we can't do that with that confidence with other designs. Or as Fisher put it, is one of the fathers of the RCT, randomization relieves the experimenter from the anxiety of considering and estimating the magnitude of the innumerable causes by which his data may be disturbed. They don't write like that anymore, do they? But isn't it awesome? So the beauty of randomization in theory is that it solves all those problems for you. In non-randomized studies, you can only control for the known confounders. Successful randomization should control for all. And even when there are imbalances at baseline, they're not systematic biases, they've occurred at random. How do you do it? Well, the old school way is to toss a coin, roll a dice. Of course, that's pretty prone to cheating. It's very easy to cheat with those things. Back in the day, there were simple random numbers tables. There are books that you can still get in old science libraries, literally of just random lists of random numbers, and you can use those to generate your random list. Most people now just use Excel or something like that to generate, or there are online programs where you can put in, or Research Randomizer or Randomize Me, you can put in what you want and it'll do it for you. Some studies with smaller numbers will use block randomization, because they randomize people in blocks. You can make sure that you don't end up with very uneven numbers between groups, which is a risk when you have small numbers to randomize. Because it's like if you toss a coin, 10 times, you're likely not to get 5 and 5. 5 heads, 5 tails. You can get quite a big difference. Toss a coin 1,000,000 times and it will be pretty much 50-50. And there are more complex methods you can ever, but the point is, it must be truly random. You must be confident when you're looking at a trial that their process of randomization was random. And there's lots of sort of pseudo-random things people try that aren't random at all, really. And you want to watch out for those. And it might be that if you know there are known variables that might be important, then you absolutely want to ensure that they're balanced at baseline, that you might stratify your randomization into different strata on that variable, just to ensure that that one variable, or it might be more than one, that you think are really important, that they don't end up imbalanced, are balanced at baseline. So that's randomization. And you know, in a fair world, that would be it. That's all you'd need to do. You could just randomize it and get on with it. But you remember I showed you when we talked about the different biases that there is a signal that randomization and not doing it properly exaggerates effect sizes. But the signal for bias is even clearer on concealed allocation. And all concealed allocation is essentially separating the randomization process from the trial, from the people bringing patients into the trial, recruiting them, and measuring baseline. So what you want to do is you want to absolutely take that out of that environment so that it can't be corrupted in the process. And where you haven't done that, where that isn't clearly reported in trials, we see larger effect sizes, which means that even when there's a plan to randomize, if you don't protect that, arguably, there's a tendency for people to cheat. Steve's got a different theory about that we were discussing yesterday, which was that if researchers are savvy enough to know concealed allocation is an important thing, then that's like a surrogate marker that they're actually probably pretty good researchers, and therefore the trial's probably of better quality. And because I have a low opinion of people, I've always just assumed that it's because people cheat when they're allowed to. Yeah, I mean, there's a really good example of that from a trial that I'm going to tell you about at the end, which is a trial that I'm going to try and use to convince you, if you ever needed to convince him, that trials are really important. And that's a trial that Bill Silverman did in the 50s on premature babies with retinopathy of prematurity. And I'll tell you about it in a bit. But they had 1950s randomization, which was a bag of black and white marbles. And you put your hand in, if you pull out a white marble, you get randomized to the treatment. You put out a black marble, you get randomized to no treatment. It was a no treatment study. And this was a trial on, I've just broken your thing. This was a trial on a treatment for retinopathy in children, a substantial proportion of which would go blind. And Bill Silverman, who was controlling the trial, was sat in his office one day, and in the other corner was the research nurse bringing a very distressed parent in who wanted her child to take part of the trial. And he was just watching, and she put her hand in the bag, and she pulled out a black marble, looked over both shoulders, popped it back in, and had another go. Why? Because it'd be really hard, wouldn't it, with a distressed parent to say, no, we've randomized your child to not have this treatment that you so desperately want. And I think, when we think what we're doing with randomization is we're actually making decisions about the clinical care that people get. That's not so surprising that if you don't protect that process, it can go awry. Does that make sense?
So by protecting that process, what that means in practice is whenever you've got someone coming into the study, there's someone who does a screening and decides whether that person's in or out. So they do this, an assessment, go, okay, you're in. So that decision, you're in, has to be made without knowing what the next allocation is going to be. So that's essentially the fundamental allocation. So that decision about whether the patient comes into the trial is independent of knowing which group that person is going to go.
So we talked about blinding already today. And why do we blind? Why in a drug trial do we blind people to what they're getting? What are we controlling for?
Essentially placebo effect, but
Yeah,
expectations.
absolutely. And you're kind of trying to control for differences in the way, when you're blinding therapists or clinicians, difference in the way the intervention is delivered. Because if a therapist knows what people are getting, and they have something vested in it, then they will change their behavior, and that can change the outcome too. Of course, we can single blind a study and just blind the patient. We can double blind a study and blind the patient and the therapist. We can blind the patient, the therapist, and the assessor in some studies. But of course, as we've already discussed today, it's very, very hard for most of our interventions to blind anyone but the assessor. And even then, with self-reported outcomes, you're not really blinding the assessor, but you can blind the person who's controlling that process of handing those outcomes out. We have trials and protocols, we design them carefully, and then you got to deliver them. And the problem is that life gets in the way and people never do what they're told, right? And people disappear and people withdraw and people don't follow the treatment. And then people swap and say, I don't want to do that, I want to do something else. So participants often don't complete the treatment. They often withdraw from trials. And the thing about that is it isn't something that occurs at random. People drop out of treatments or withdraw from trials for very specific reasons. And those specific reasons could well be important effect mediators. So one of the things that we absolutely need in a trial is to know exactly who stayed in the trial, who left, have some reasons for that. And we need to know how it was managed. So let's take an example of constraint-induced therapy in stroke. Do most people know about constraint-induced therapy? That's a therapy where it's this idea. Hello? That's that idea that in stroke, in order to sort of force people to use the affected arm, you essentially restrain the good arm down, strap it down, and then force them to do it's actually usually highly intensive task practice with the unaffected arm. So you might have a trial of constraint-induced therapy versus usual rehab, and end up with quite high dropout rates, disproportionately high dropout rates in the constraint-induced therapy arm. What might drive that, do you think? Absolutely. So people just aren't prepared to tolerate that. If you might not want that restriction of not being able to use the arm. They might feel that they're not making progress. But the point is, if people are withdrawing from the study and then we ignore them, that might skew the results. If people withdraw and don't take part in the constraint-induced therapy and we exclude those people, then that group no longer have that. We can't be confident that they have that balance that they had when we randomized them. Yeah, because they haven't dropped out at random. So when you're looking at a trial, the sort of basic questions you should ask are, how many people dropped out? From which group and when? What reasons did they give for dropping out? Was there a big difference in dropout between the groups? And how was the missing data managed? How was the analysis performed with regards to that not completing the protocol or leaving the study? And the two basic approaches to analyzing a trial are per protocol or intention to treat. With the, generally speaking, intention to treat is regarded as the more reasonable and balanced and unbiased approach to doing it. But again, it depends a little bit on what the question is that you're asking. But in a per protocol analysis, we only include the participants who complete the trial or treatment to which they were randomized in the analysis of that group. In an intention to treat analysis, we analyze people who were randomized to that group, regardless of what happened after that randomization, whether they withdrew, violated the protocol, didn't adhere. So it looks a bit like this. If we had a trial where we randomized 100 patients to a treatment and 100 to control, in the treatment group, 20 were non-adherent and 80 were adherent. In our per protocol comparison, we'd only analyze the 80 adherent patients. And in our intention to treat comparison, we'd analyze all of them, whether they adhered or not. Does that make sense? Another way of looking at why we do intention to treat rather than per protocol, have a look at this badly animated randomized control trial that I've drawn. We have a bunch of people with the same condition, and we randomly allocate them into two groups, intervention and control. And at the end, in the intervention group, we see this, a few people have got better, a few people no difference, but a few people are substantially worse. Whereas in the control group, we've got this, half of them are better and half of them are unchanged. So if we estimate on average then, what's the difference between groups after treatment, then outcomes are trending towards being better in the control group than in the intervention group. But let's say those people who didn't do well in the treatment group left, or just didn't complete the treatment, or just stopped with the treatment. And then we do a per protocol analysis. Well, now our effect estimate is going to look like this, because we've got 4 out of 5 did really well compared to what we have down in this group. So you see how that would give an unrepresentative view of the actual effectiveness of the therapy. And it might be that they don't do that. It might be that they just swap over into the other group where they kind of become a bit more neutral. But again, if we analyze them into the groups that they end up in, rather than the groups to which they're randomized to, we end up with a skewed view of the effectiveness of the intervention.
If you start to do intent to treat analysis, if they look,
As in when you don't have data?
yeah.
We'll get to that.
Okay.
Yeah, absolutely. That is a big question.
Okay.
So we prefer an intention to treat analysis because it preserves that randomization. The randomization gives us that balance between the groups. As soon as we start excluding people who don't drop out at random, we lose that confidence and that balance between groups. ITT is more realistic to the clinical real world. The fact is, if you roll a treatment out to loads of people, they're not all going to get on with it. They're not all going to do well. And we can't base our conclusions on only those that did. And it's more likely to prevent serious biases. But the problem is, what do we do where we don't have data? So in an ideal world, even people that didn't complete would just keep filling in the outcome forms and giving us their data. But actually, people disappear, people aren't prepared to continue, and you lose data. So there's a lot of different ways you can approach it. One is to do an available case analysis, which is essentially only to include people for which you have the data. But you can see how it's almost moving towards a per protocol kind of situation, in that the data that are missing aren't missing at random. Yeah? You can count them all as a treatment failure, which is not a great way of doing things either, because it just assumes that none of them got better, and that's an assumption that might not be reasonable to make. You can impute data, and imputation is essentially what statisticians call making stuff up. It's putting in a value that isn't a real value. It's a value that you're gonna guess at. At the most basic level, people use tools like the last observation carried forward, which is take the last outcome measure you have for that patient and just plug that into all the empty gaps on the spreadsheet. But the problem with last observation carried forward is people often withdraw after things aren't going well, or after they've had an adverse event. And it may well be that the data point before that actually doesn't reflect that. It's too positive. And we've got some evidence in the pain field that last observation carried forward analyses tends to exaggerate effects and underestimate adverse events and harms. Another solution, which is preferred by some of my colleagues at Cochrane Pain Group, but I'm still not that keen on it, is baseline observation carried forward. So you just take what their measure was at baseline and you plug into all the missing gaps. But then you're getting a really conservative estimate of what happened in that group, because you're not even getting natural history and regression to the mean and all those other things. So that's not giving you a fair representative way of doing it either. And then the statisticians have got lots of approaches to multiple imputation, which essentially looks at the data set and probabilistically works up what likely values might be and plugs those in. It's very complicated. I think you need a stato to understand it and do it. But in the end, it's all estimating and guessing. If you are going to impute data, it's probably the least biased way to do it is through multiple imputation methods. But if you've got a lot of dropout, and that dropout is unbalanced between groups, and there's missing data in there, it doesn't really matter what you're doing, there's still substantial concerns about the answer that you'll get from that study.
Even if, so say you had your two groups and like 3 people dropped out, but you still can't assume that you can't say that's like equal dropout because we're assuming that it wasn't random who dropped out.
But you can't assume that the dropouts are random. So, I mean, if you have a little bit of dropout, you're always going to have a little bit of dropout. If you see a big trial with no dropout, you should be worried about it. So you're always going to have some. Yeah. If it's really low numbers and it's pretty even against groups, it's probably not going to have a big impact on the outcome. If it's large numbers, even if it is even against groups, if you get up into 30, 40% dropout rate, you've got big concerns about that. And if it's large numbers and it's imbalanced across groups, that really speaks to something different is going on in one group. And so you really have a non-random problem going on there. And all these things are sticking plasters for a problem that is impossible to solve. And you have to have a look at it and say, well, is that reasonable enough? A lot of big trials, they'll do lots of sensitivity analysis where they test the assumptions of their imputation. So they'll plan a good way of imputing data, but they'll look at the parameters of that and what happens if we change it. Is our effect estimate, is our answer robust to doing this in different ways? And if it's not, that's a problem. It's all guessing, but it's just about how educated a guess can you make. So none of the methods are perfect, but effects are exaggerated if we exclude people post-randomization and where dropout is high and even. There's always cause for concern. And here's the thing, this is always true of all these things. If it isn't even clear what happened, that's just essentially pretty unforgivable. Good, clear reporting is the cornerstone of good science. And if you can't tell, if the data just isn't there, you can't really make sense of that trial at all. So we've done this already, but just to sort of go through all those features and talk about the types of biases that we're looking at. This is a table I've taken from Cochrane. So randomization sequence generation is about selection, allocate, and allocation bias. Blinding of participants and personnel is about performance bias, things that might affect the way that the intervention was delivered. Blinding of outcome assessment is about detection bias, so biases that creep into that measurement process of our outcomes. Incomplete outcome data reporting, who left, how many, how did they address that? That's about if there are big differences or if they didn't use intention to treat or if it isn't clear, that's a study that's at risk of attrition bias. And then last one, which I haven't touched on much, is all the outcomes that they said they'd measure fully reported in a way that you can make sense of. And if they haven't done that, then that's selective outcome reporting, which is a risk of reporting bias. Yeah.
Outliers, detection and treatment outliers.
It's actually, in the trial world, you don't do much of that. I think the thing about outliers is, how do you know when someone is an outlier or someone just has an extreme value that's quite representative of what you got? And I think smoothing data and picking out outliers gives researchers an extra degree of freedom that is easy to abuse. So generally speaking, in most trials, you won't see a process for looking for, identifying, or excluding outliers. Because actually, as soon as you start excluding outliers, you're kind of reducing the external validity as well. But yeah, I know in lab science and psychology, and in fact, a lot of sciences, it's quite common to look at the data set. But I mean, whether it's good or bad practice, I think it's probably an ongoing debate as well. I love this comment because actually, we talk about, well, I do the trial, we randomize people, we give them the treatment, we measure them at the end. Brilliant, right? But actually, with most of our interventions are complex. And remember, we were trying to work out what dry needling looks like. Well, what does it look like? How should it be delivered? How do we know it was delivered properly? How do we know people did everything? And often, you can't tell from the trial what actually happened in that process of intervention delivery. So when we're looking at, say, let's take core stability exercises or a CBT or an ACT intervention for back pain, we can ask ourselves, we can just look at it at a very macro level and say, one group got CBT or ACT and one group got usual care, and this is the difference. But what did it actually mean to get CBT and ACT? And it kind of speaks to this issue of understanding what the intervention really was, what people were given, and how well it was delivered and how consistently it was delivered. And so you've got issues of, what is the intervention? What's the theoretical basis? How is it operationalized and individualized? And do we have some ideas that was actually done consistently to some sort of recognizable plan? How expert were the therapists who delivered this? How well trained were they? You know, do we think that at the level of expertise that's been reported, they're capable of delivering this intervention at a higher quality with fidelity? Did anyone monitor whether what was said was going to happen actually happened? So a lot of the trials units will be sending research associates around to all the clinical sites on a regular basis to monitor what's going on. My colleague Pete Heine pretty much spent 2 years on the SARA exercise trial for RA, driving around England, watching people teach exercises for exercise RA. How do we know that the treatment was delivered there? What information do we have about how people engage with the treatment and whether they adhered to the treatment as well? All of these things come into what happens when we test a complex intervention. I think at the level of systematic reviews and trials, only now is the community really engaging with how important that stuff is. And when you go back, particularly to older trials, you get almost no information from the trial report about that. But as we go forward, we've got new reporting guidelines and things like that. We'll see, hopefully, the standards improve. But, you know, if someone says, well, core stability didn't work for this group, you still have to ask yourself, well, what was it? What was delivered and how well was it delivered? We now have, we get lots of different standards of reporting for trials. We now have the TIDIA checklist, which is a checklist of things that in an ideal world would be reported in trial protocols and reports. And it's about understanding what happened and being able to replicate that as well. So Tammy Hoffman is an Aussie researcher, did a systematic review of complex intervention studies and found that of 137, only 39% of them were adequately described. And they made the comment that missing an essential information about interventions is a frequent yet remedial contributor to the worldwide waste in research funding. If all you've got is a 3-sentence description of what went on for something like CBT, well, that intervention's a black box. You know, it's just a label. And trying to improve the depth and the quality of reporting around complex interventions is one of the big challenges, but I think it is improving. We've said that size is important. We need nice big studies to be able to detect differences if there's there. Increased size leads to a more precise, reliable estimate, but of course, we have that issue we've already touched on, that small published trials are more likely to show big, significant effects, and that's a publication and reporting bias issue. All trials should be registered on a trials register at their inception. You know, when you're planning the trial, there should be a record. And actually, when you guys are reading trials, it's worth looking to see where that is and go and have a look to see if what they've written in that trials register record corresponds to what's actually reported, or whether there seem to be fundamental differences. But trials register records are really limited in information. So what's happening much more now is detailed protocols being published, and BMJ Open's a good journal for that. BMC Musculoskeletal Disorders is another good journal for publishing protocols. But if you've, do they do it now? I mean, generally speaking, if you've got a trial and it wasn't registered, that should raise your index of suspicion about a trial. It's not good research practice.
Quite a few of the journals might publish RCTs. So about 2-3 years ago, pretty much all the big physiotherapy journals signed up to that. So none of them will publish an unregistered trial. And similarly to the TIDIA statement as well, just last year, where they've all said we're not going to publish anything unless it meets these criteria.
Yeah, I mean, so that's really important. And actually, when you're reading a trial, it's actually quite good fun to pull up the protocol next to it. Just as a little bit of detective work, because it might absolutely restore your faith in humanity, or it might not. And then I just wanted to run through a little rogues gallery of fun stuff that you find in trials which represents bad practice, but isn't really captured on the risk of bias tool or the Pedro scale. Because, a trial that does some of these things is kind of it's not a gold standard. It's more, it's like, that old line that you can't polish a turd, but you can roll it in glitter. That's really more what you're talking about when a trial does some of these things. They're really bugbears. So they don't show a difference between the two groups at the end of the treatment. So they focus their attention on how much better the treatment got from baseline. Why would you do that? Well, it's certainly not the comparison of interest in the trial, but it normally tells a much happier story than the between group difference. But if you have a study that shows that people change from baseline, but you didn't see a between group difference after the intervention, well, that's a negative trial. If you've got a comparative effectiveness trial of 2 interventions, this is where you really see that, is you got, I don't know, we might compare this exercise program with this exercise program plus fancy taping for shoulder pain. And there's no other control group. And you follow them, and there's no difference between the groups, but both groups did quite well from baseline. Then they conclude that both treatments worked, which is a fallacy. You don't know both treatments work. You just know that in both groups, there was some improvement. Yeah. And I find it remarkable how common that still is in the physio literature, but it's kind of it's a sin. It's a sin. The surrogate outcome gamble is a really good one. The drug companies were really the leaders in this. So if you can't show that your statin reduces incidence of stroke or other cardiovascular events, you might be able to show that it reduces blood pressure. And then use that to say, so it must reduce these things. So it's focusing on something that isn't really the outcome of interest in order to build the case. So in core stability, it might be that you deliver a core stability trial and you don't really show an effect, but that transversus abdominis came on quicker. So we must be doing something good. It's not the outcome of interest. It's focusing on an outcome that you can build a picture from, but doesn't actually demonstrate clinical effectiveness. Post hoc subgroup hunting, which Melissa kind of touched on. I'm going to let Steve talk about that more than me because he's the subgroup expert. But that's this idea that we don't see a difference between the two groups, so we're going to go hunting for the people who did get better. It's actually really hard to do that because you'll always be able to find people who improved, but it's much harder to show that there were a bunch of people who specifically had a treatment effect. And that's the challenge.
But one can, few groups that their diagnosis and exclusion to begin with, so it's a super heterogeneous population. Who even knows if they're the same disease processes? And you don't have any good information otherwise. The diagnostic information is not giving you anything to go on. There aren't any peripheral, pathologies.
Yeah. But you've got a problem, no doubt. But there's still, there's still not a way of identifying. Well, that's not true. It's still very hard after the fact to have a look through and say those people are responders. It goes back to that idea that I go to IASP every other year and I go to see all these presentations talking about responders, and I sit at the back saying they're not responders because they're not. They're just people who got a bit better. You can, if you hypothesize there might be subgroups, then maybe you design your trial for the specific subgroup of interest. Maybe that would be the best way to do it. Or if you've got a hypothesis about subgroups, then you might power up your trial to detect an interaction on that subgroup variable of interest. But if you just do your trial and then go looking for the people who did better, that won't really ever tell you that there are subgroups of people for whom the treatment's effective. It just tells you that some people get better, which we kind of knew already. P-hacking. Yeah.
So there's also a mathematical issue. We've got no difference between two groups, your treatment group and your control group. And you say, okay, we've got this subgroup of people who respond to our treatment. In order to maintain that zero difference, you have to have a subgroup of equivalent size for which your treatment is harmful. So in order to make the maths line up, so you have to be willing to say that as well. So okay, I've got my treatment, PET treatment, no difference between the PET treatment and whatever else, but we think there's this subgroup that's really important. As I said, in order to make that maths line up, then you've got to say, okay, now there's also this subgroup which has done much worse. So for effectively, for which this treatment is harmful. And again, that's something that you see this discussion about, yeah, there's subgroups of it, but what about that other sub? Either that or everyone else at this very tiny, a tiny detriment. Particularly if you're saying the subgroup is relatively large. If you're saying it's 40% of the sample, then you've got to have a big subgroup who's done badly, or a small subgroup who's done really, really badly, in order to make that possible.
P-hacking is something that happens quite a bit, which is, if there's that old line, if you torture your data for long enough, it will confess to something. And, we say if I run one between group comparison, say a t-test, for instance, with my probability of a false positive set at p equals less than 0.05, that's fine. If I run 10 t-tests separately, and one of them comes up as p equals less than 0.5, then the actual probability of a false positive is 0.5, it's 50%, because it's that times 10. So the more tests you run, the higher the risk of a false positive. And there's all sorts of ways in which if you keep running tests and you keep doing different analyses, you'll find an answer that you want, but it might not be the answer that's true. And then axis cropping is my final one. And I just put this in there because it interests me, because it's such a fantastic thing that people do on a regular basis. This is some data from a trial of repetitive transcranial magnetic stimulation for fibromyalgia that we reviewed. And in the first version, this was the only actual reporting of results. There was no numerical results reported. It was just this graph and some p-values. And they said, look, the treatments worked really well for pain. And you can see that it has, because these are the pain scores in people who got the real treatment, and these are the pain scores in people that got sham. We've got some statistical significance. This is looking fantastic. And we've not got many good options for fibromyalgia. But then I just thought, hang on a minute. How do we measure pain? On a what scale? A 0 to 10 visual analog scale. And the great thing about a 0 to 10 visual analog scale is it's not very big. So, you can fit the whole scale on a page. You don't have to crop it. These guys have cropped their 0 to 10 pain scale down to 2.5 points. Why have they done that? Because it makes it look bigger. Right? So we said, look, can you present the graph the other way? And this is the published graph of the same data. And it's the same data. It shows exactly the same thing. But it looks far less compelling, doesn't it, presented that way? So it's always worth having a look at that. Consider how big is the scale and whether they've cropped that axis. Now, there are good reasons. You've got massive scales. There are good visual reasons for cropping, but not really on a 0 to 10 pain scale. There's lots of arguments about, how useful trials really are in physio. People feel that trials crowbar people into a kind of one-size-fits-all kind of process, and that's not, for instance, how physiotherapy works. And of course, that's true of some trials. It's less and less true of most trials. And actually, most trials now go through quite a lengthy intervention development process and work out who the intervention would be appropriate to deliver to, and you recruit those people. How should it be individually tailored, and what flexibility can we allow therapists to individually tailor and progress and all those things? I think a really good example of that is the PROMISE whiplash trial, which is a really complex intervention for whiplash, chronic whiplash with, it's got a bit of manual therapy, it's got exercise program that's individualized, it's got advice, it's got sort of CBT type skills for post-traumatic stress where those issues are. And the clinician does a thorough assessment and tailors that. And it was their idea of the best model practice of care based on their understanding of whiplash. Now, that showed absolutely no effect compared to a very limited intervention. And then people were saying, well, trials, one size fits all. But actually, that isn't what happened in that trial. That trial was assessing a complex intervention, individually tailored and individualized to people. And so that one size fits all argument doesn't always stand. People will say, look, the real world is too noisy and complex, and our treatments work. We can't detect the signal over all that noise. But of course, actually, if you think about what you're doing in practice, no one gets to deliver treatments in a soundproof room, right? And you talk about persistent pain. Well, people have messy, complex, noisy lives and persistent pain. So, the challenge for any treatment is to be able to reliably show that it improves outcomes in the midst of that noise. And if it can't do that, but it could do it under absolutely ideal conditions, well, that's a scientifically interesting thing with almost no clinical utility at all. because real patients have complex, messy lives. And then there's the subgroup question, which we've already touched on. And when people are arguing why RCTs don't necessarily show how great their treatments are, they forget that the majority of RCTs in the therapies contain a number of biases that broadly favour the therapy and investigation, not least our inability to blind studies. But we saw when we looked at the Pedro scale how many different biases we might expect to see in trials. So with subgroups, we need to make sure we've got a theory about that, that we established before we saw the data. We should only really look if there is some sort of effect size to look at. Otherwise, you're doing the equivalent of digging through a big pile of horse poo looking for the pony, right? You've got to power your study and design it to detect those effects, no pony searching. You don't always need an RCT to know that a treatment works. Loads of people show this old argument. There was a joke article in the BMJ. Parachute used to prevent death and major trauma related to gravitational challenge. A systematic review of RCTs. And what these guys were doing were laughing about this paradigm of RCTs that, you don't need an RCT to know that you need a parachute jumping out of a plane. And they were making that analogy to say, you don't need an RCT for us to know that our treatments work. You only need an RCT really where you need to control for biases. You only need an RCT if there is uncertainty, otherwise it's a pointless exercise. And sometimes, as we said, it's not ethical. But I would argue in our clinical fields, there aren't many parachutes. There aren't many interventions that I'm trying to think of any actually, where you could say without a shadow of a doubt, I know this works just from observing it in the clinic. There aren't many at all. I think the other thing about the parachute argument is, do you think anyone jumped out of a plane with a parachute before they'd pushed a few pigs and cows out first and tried it out? They still tested parachutes before the first person jumped, right? So it's not like, well, a parachute's so obvious that we didn't need to do some sort of testing first. So anyway, what does this trial mean for your practice, which is ultimately what you're interested in? It's worth thinking about that in terms of PICO again. And this is exactly the same thing as we were talking about earlier with critical appraisal. Are the participants similar enough? Is the intervention similar enough, appropriate, feasible? What you would deliver? Is it a good reflection of the intervention that you wanted to know about? What did they compare it to? Because that really changes how you interpret the answer. And were the outcomes important, and what's the effect size? If you have doubt, are your doubts logically justified, or do you just want to hate on this trial because of the answer that it's given you? This is the CAST tool broken down, but we don't really need to go through that because you're about to do it. Just a couple of last things. No trial is an island. So you can't take one trial if there are 10 in existence. Actually, and that's why we can talk about systematic reviews later on in the course, is that a trial is fine. It's one estimate of the truth to that question. But what we want is all the estimates of the truth to that question so we can really get our best answer. And just to convince you that trials are fantastic, we're back to Bill Silverman's babies. So back in the 50s, no one was doing trials in neonatal peds. And they had this condition of retinopathy of prematurity where these babies born prem had like what they thought was an inflammatory eye condition, and a substantial proportion would go on to be blind or permanently visually impaired. But some just got better. And Bill Silverman, who was a doctor there with interesting stats, one of his friends there, another doctor, his wife had had a number of miscarriages and was pregnant with a very wanted baby, which came premature and had this condition. So he said to Bill, what have you got? And he said, well, we haven't got much, but we think if we use sort of steroid treatment, that might be something we might try. So he said, well, do it. So they tried the treatment and there were side effects and they titrated the dose and the child had a fantastic outcome. So they thought, well, maybe we're onto something here. So then they did a case series. So the next 31 cases that came through their hospital, they delivered this treatment to, of which 25 had essentially an excellent outcome, and they had 6 fails. And then they didn't have much of a control group or any control group there, so they compared it to a neighbouring hospital in a neighbouring state who only had 7 cases, all of which ended badly with vision impairment or blindness. So now they thought they were really onto something. And just take a minute. If you had an intervention that you like to deliver for patients for a specific condition, and out of 30 patients who'd come through the clinic, 25 had absolutely rocked their outcomes, would you ever allow me to come at you with an RCT or a systematic review and tell you that that treatment didn't work? I suspect not. It'd be really hard. I mean, actually, that would be more compelling evidence than we usually see. It's an incredible set of results. But then they did the trial, and that was the trial that we saw that nurse cheat the randomization sequence for. And the results of the trial are that a third of babies treated with ACTH, the treatment, became blind. But only a fifth of babies with no treatment became blind, and that difference was statistically significant. And at 2 years, mortality was significantly higher in the treated group. And the kind of really sobering and emotive upshot of that is you have a treatment that looks absolutely fantastic for a condition with horrible outcomes potentially. But if they'd never done the trial, to this day, they would still, with the best intentions, be blinding and killing premature children. And that's kind of, for me, I know it's kind of a really stark example, but for me, if ever anyone needed convincing that we need to do RCTs in order to know if our treatments work and are safe, then in my view, that's the one. You know? So now, that's it. It's workshop time. So you have 2 trials. One, COSTA, which is a trial of motor control exercises for back pain, and one by Ludvigsen, which is a trial of a number of different interventions for people with neck pain. And you have a CAST tool, which will take you through the questions to ask about the trial. So it's probably worth doing it in a group if you can.
Around and Jamie
and then discussing each section of the form as you go. And then Steve and I will float around and get involved in any discussions.
Jamie's around, he's looking for an image of a cow or pig parachuting.
Okay, so I'm going to stop.